Good morning, everybody. Thank you so much for joining today. My name is Hilary Karasz, and I'm the Deputy Communications Director at Public Health Seattle and King County. And I have the privilege of moderating this really interesting panel today. We'll be building on the previous conversations that we're just having, and we'll take about the next 45 minutes to look at concrete actions that can be taken before an infodemic occurs. Just to comment that, many of us as public health practitioners have spent hours planning for emergencies through tabletops and emergency exercises. We do practice communication responses, such as reviewing how to find pre-positioned health information, and we review our dissemination channels as well as who on our staff will be part of a surge response. We do risk communication training, incorporating concepts such as establishing our institutions as trusted sources of information, incorporating regular updates to our residents, demonstrating empathy about the crisis, and reminding people what we know and what we do not know. But planning for an infodemic is new to many of us. This panel will help us understand some approaches we may be able to take and challenges in specific settings. So as I mentioned, we have a super interesting panel today representing a range of experiences. Ian Brooks is the director at the Center for Health Informatics at the University of Illinois, Urbana-Champaign, and he'll be telling us about tools to identify and categorize misinformation across the information ecosystem, why and when to take action. Lisa Cox is the communications director at the Missouri Department of Health and Senior Services and has on-the-ground experience during the pandemic managing information across her state. And Dr. Norman Oliver is the former state health commissioner at the Virginia Department of Health and has a wealth of experience in the practice space and will share his ideas, assuring that we are prepared for the next crisis. I'm going to invite each speaker to share their remarks. Each has about 5 minutes to speak, and then we'll have a question and answer period. So with that, Ian, please go ahead.
Thanks, Hilary, and thanks to the Academies for giving us the opportunity to share some of the infodemic work we've been doing. As the PAHO WHO Collaborating Center on Information Systems for Health, we focus on the use of data from traditional and non-traditional sources to support public health decision makers. When the pandemic hit, PAHO came to us with a challenge to help support the member states and other public health organizations. So they asked us, is it possible to help those organizations identify new and emerging misinformation threats, evaluate the threats, and make recommendations on how best to respond? Can we do it within a week? And can we do it with the minimal amount of human input? So it's a pretty overwhelming challenge, but with support from the WHO COVID Solidarity Fund, we established the PAHO WHO Anti-Infodemic Virtual Center for the Americas. It was initially a 6-month proof of concept project. So we organized the center into 3 international multidisciplinary teams, and this comes back to the requirement for people from many different disciplines. The 3 teams were detection, evidence, and response. The detection team is led by data scientists. They developed algorithms based on machine learning and artificial intelligence to monitor social media for new and emerging misinformation stories. We did it initially in English and Spanish. We also developed approaches to automatically follow other infodemic and fact-checking organizations. There's a lot of people out there doing that, including Chris and CDC and others. And we developed a couple of other approaches as well. The evidence team is led by information scientists and the Librarian Reserve Corps. They're a group of volunteer medical librarians who came together to help WHO with COVID research. We worked to modify the Easy Search federated search engine. The goal is to identify 3 or 4 recommended papers, websites, or dashboards that can provide the information a senior public health official needs to understand the misinformation. So think Google, but instead of having 100,000 results, you get 3. The response team is led by behavioral scientists, and we use a storytelling framework for any response that we recommend. I'll come back and give an example of that in a minute. So as these three teams each worked to develop their own methods and approaches, it became clear that we needed to develop our own misinformation classification scheme. This was really because as we started looking at some of the examples, the methods for one type of misinformation don't necessarily work for different kinds of misinformation. There's not going to be any scientific literature, peer-reviewed literature for the theory that COVID virus came from 5G networks. So our current working model has three types of misinformation: misunderstood science, conspiracy theories, and belief as identity. We also discovered that we needed a way, and I think this came up in the last Q&A, to evaluate the hundreds of pieces of misinformation we detect each week and decide which one are we going to focus on. We only have the resources to focus on one each week. And there are two major components to our evaluation. We look at the underlying data, and we looked at the predicted behavior. So on the data side, we prioritize those threats that are being seen by lots of people, that we see on different social media platforms and other sources, that we see in multiple languages, and those that are becoming more widespread. We also make note if the misinformation originated or is being spread by a well-known figure or an influencer. You know, is it more likely to become viral on the behavioral side? Is it culturally and geographically relevant? Or maybe the critical question is it likely to cause people to make bad public health decisions? So even if piece of misinformation is common knowledge, it doesn't mean that it will necessarily have a major impact. Perhaps somewhat unusually, we also ask, can we actually come up with a response that will make things better? As Chris said, there's so much information out there, we don't want to make a response that will make things worse. So as a short example of our storytelling approach, we discovered a threat that was being spread widely by a White House correspondent who claimed that the vaccine contained a synthetic marker called luciferase. And they gave the proof that if you don't believe us, go look up the patent application and luciferase is in there. It's true. Luciferase is the name of a class of enzymes that gives off light. They are used widely as a tool in molecular biology. They were used in the development of COVID vaccines, but they're not in the vaccines themselves. Our recommended response, though, was to focus on the beliefs of those likely to be influenced by the threat. We acknowledge that the origin of the words Lucifer, the devil, and luciferase are the same. It's Latin meaning light-bearing. And we recognize the fear in the old stories, but said that far from something scary, luciferase was actually something to be admired as a marvel of nature. Without luciferase, you don't have fireflies, you don't have glowworms, you don't have other bioluminescent organisms. So I probably used my 5 minutes. It's a very, very brief overview of the Anti-Infodemic Center. The overview paper, I believe, is in the workshop documents. Please feel free to contact us if you want to know any more, and I'm very happy to take part in the discussion. And thank you.
Oh, thank you, Ian. And what you've described really, I think, has a great potential to be a really practical tool for practitioners. And I hope we get to hear a little bit more about it throughout this panel. Now we will hear from Lisa Cox, who will share her experiences as Communications Director at Missouri Department of Health and Senior Services. Lisa, please go ahead.
Thank you. Thanks, Hilary. I'd also like to thank the workshop planning team for inviting me today. Very much appreciate it. So when I began thinking about what I would like to cover today, I spent a lot of time thinking about all of the emergencies I've responded to in my career, from one of our nation's most devastating tornadoes in Joplin, Missouri, to some high-profile criminal acts during my time in law enforcement, to the COVID-19 pandemic, of course, plus all the smaller ones, smaller, more short-term emergencies that were in between. And with all of these, it's been my duty to communicate to the public and to the media, sharing what I can, getting ahead of the story as much as physically possible to avoid the story really taking on a life of its own and quickly turning into what we now know of as an infodemic. And as I thought about all these crisis communications events, I realized that the common denominator for the most successful outcomes was not something that you would find on a checklist in one of our emergency response plans, wasn't a skill that you would take a class on or become certified in. And what I'm talking about has really been a theme so far today and throughout this workshop, and that's relationship building and trust. And I know this isn't a brilliant light bulb moment for anyone on the workshop today, but building relationships, having trust in those relationships is really an important part of our lives in general, right? Professionally and of course personally. And Deetram and Nancy, I think, spoke of this in the first Q&A, specifically as it relates to those media relationships. But what do relationships have to do with preparing for emergencies in the future? And as a communicator, I think the number one best way to prepare for an emergency is to work to cultivate those important relationships now. Continue to nourish those relationships that are already in existence and find those people that you need to know, your partners, your stakeholders, your community leaders. Find them, engage with them, communicate your goals and mission to them. And trust isn't earned overnight, and it's certainly not earned in a high stress emergency response environment. Yeah, I manage the communications for our state's health department. And when COVID-19 hit, no one truly knew what to expect. How long will this last? Am I at risk of getting really sick? Who should I listen to? And especially in this situation with the novel virus, we all know there was no solid playbook. But as a communicator, I firmly leaned on the relationships that I had, the same relationships that would be beneficial regardless of the type of emergency. And these are the relationships that allowed that trust that had already been built in me and therefore our agency to result in trust of our collective response to that situation. So when the public was yearning for one consistent message that wasn't layered and politically driven sentiment, we were that voice. And don't know much about Missouri. Missouri is a very, very diverse state. We are home to 115 local public health agencies who operate autonomously from our agency. We have densely populated urban areas of Kansas City and St. Louis, but then we also have about half of our state's population living in rural areas, many of them being red counties with much lower levels of access to both healthcare and internet. And for these reasons, our messaging strategies throughout the pandemic and every statewide emergency has to be very diverse, targeted with different approaches. So it was those solid relationships that allowed us to quickly put a conference call together and coordinate statewide messaging. And those touch points will remain throughout the entire pandemic. And it was the trust that was built over time that caused our partners to decide to join forces with our team and promote the same message and same website for those sought after resources. It was us as the public health officials having strong relationships with our agriculture department representatives who served as a messenger to our state's farming communities. Those trusted partners became trusted messengers in our local areas, whether it was one of those 115 local public health agencies, a local church pastor or doctor, the consulate of Mexico in our Spanish-speaking communities, a barber, or just a well-respected and well-connected small-town resident. Those are the people that we worked with as public health experts. We worked with them directly to provide them the messaging that we so desperately needed to share in those times. In addition to those relationships, just as mentioned earlier today, a relationship with the media is incredibly valuable and underrated, in my opinion. While it's very easy to criticize the media and paint them all with a broad brush, these relationships can be mutually beneficial. In an emergency, the media will find someone to talk to regardless because they have airtime to fill, right? And you also can't limit those relationships to outlets that you feel may be fair or balanced or even sway in the direction that you need them to. Actually building relationships with the media outlets that can lead in the opposite direction are probably even more important. If you can have those honest and open conversations with the media partner and not a nemesis, you're bound to get further with your truth. So again, before the emergency strikes, take the time to build those relationships with your area's media outlets so they know where they can turn to in a time of uncertainty and crisis, so that they can gain honest, accurate information that they in turn can share with their audience, regardless of who that may be. As experts, I think we should all desire to be the person with the microphone to have the best chance of allowing that truth to prevail. So that's all I've got today. Hilary, I'll turn it back over to you. Thanks.
Thank you so much, Lisa. And I really appreciate the discussion of considerations for the importance of relationships and trust in preparing for infodemics. Dr. Oliver, I'm sure you'll have some comment about that. If you can please go ahead.
Thank you, Hilary. Can you hear me okay? Excellent, excellent. Yeah, a lot of what was said by Lisa is something that I will echo. And I think actually the entire morning we've been hearing things that are quite relevant to what we need to do to prepare to fight infodemics before we are faced with another one in a disaster. And speaking of disasters, I really feel strongly that we need to follow the guidance of our colleagues in environmental geography, who would point out that there's no such thing as a natural disaster. Every disaster has with it, we well know, huge impacts that vary across racial categories, across social class, across actual geographies. They all play a very big role in the outcomes of those disasters. And we know that this intersectionality is something that's true. We know it in terms of our own public health practice. You take any disaster, hurricane, tornado, floods, pandemic, and of course, it's also true with infodemics. The people who are going to be the hardest hit by that are Black and Brown communities, rural communities, low-income communities are the ones that will suffer the most. And we know that ahead of time. So I think one of the lessons that we really need to draw about how to deal with infodemics and any other disasters is that beforehand we need to integrate into our response and into the structure of our response a way to deal with these issues. So for example, in our ICS, our incident command structures, at the general command level, I believe it's really important that we have people assigned to look at, through an equity lens, everything that we do in our response in terms of communication, our finances, logistics, operations, planning, the whole gamut of what we do. With respect to infodemics, I think that a number of things that have been said today are really important, and Lisa hit on a couple of them already. Being able to really target our messaging, having the right message means targeting that message. You have to speak differently to a rural community than you would to an urban community. You have to speak differently to a community that is politically, very Republican, for example. And you can do so without changing the content, not the actual content of your message. You're actually speaking in a different way, speaking to values that are strongly held by those people, and based on those values, telling a story that can help them see that living those values means, for example, getting the vaccine or whatever it is that's necessary to deal with the issue at hand. There's a whole science to doing this. Communicators in private practice and in industry, academicians who study community science, communication science, as we heard in some of the earlier panel discussions, know this science. And I think public health practitioners need to join with them before we have disasters to learn that science, to re-educate and develop our current communications workforce within public health, to develop partnerships with these folks so that it helps us going forward, that we learn this science. We need this public academic partnership, and we need a partnership between public health and private industry, which also knows how to do this very, very well. And to our CDC colleagues in the audience here, I would strongly encourage something akin to our EIS, only instead of being focused on epidemiology, we need some EIS officers who are focused on communications. And I really enjoyed Tina's comment in the first panel about how WHO has these infodemic managers that they're training. We need people like that, and it would be helpful if the CDC or others could help us out in that regard. In addition to having the right message, we all know that you need the right messenger as well, trusted individuals. In Virginia, we did, as Lisa was describing in Missouri, we had a big effort on using community-based organizations and our partnerships with them so that they could be the ambassadors in those communities, really talking to people about the necessity of getting vaccinated during the COVID-19 response. We were able to do this, however, because those partnerships had been built already. And I think that's a really key point that was made in the earlier panel. You have to build these trusted relationships prior to the disaster. It should be part of our ongoing work. One of the things that we learned, however, in the Public Health Wins survey is that a lot of public health practitioners feel that they don't know how to do this, right? They don't have the expertise in building these relationships. You look at the 10 essential services of public health, we all know how to do that. But on this issue of building community-based partnerships, we need more training, and we need to then use that training to build those relationships prior to the disaster. And by doing that, we build a kind of trust that Lisa and others have been talking about. And you can then, on the basis of that trust, find the trusted messengers we need to combat infodemics. And with that, Hilary, I'll kick it back to you.
All right. Well, thank you very much for 3 really interesting panel presentations there, talking about an excellent new system to identify themes and stories that are out there that are misinformation or disinformation, and then how to actually implement communications on the ground in different states. So I just wanted to give Ian an opportunity just to tell us a little bit more. You mentioned a story, an example of misinformation that was not worth responding to because there's just really no way to counter that. But what are some examples of things that we can respond to, and how do we do that, Ian?
Well, the example I gave was one we did respond to, was the luciferase. That was just a good example of what we did respond to. So I guess I'm not entirely sure your question.
Ian, I think we're having a little bit of a audio trouble. Maybe that explains my mishearing some things. So while we're trying to fix that, I want to go over to Lisa and ask just more on the preparedness side, Lisa. In what ways did you feel prepared from a communication standpoint, Lisa, going into an emergency response situation?
So there were definitely some ways I felt prepared going into specifically the COVID-19 situation. And going back to, I mentioned a lot about the relationships. And if there was one thing I was thankful for before 2020, it was the fact that I had some good, solid relationships already before that. So some of our administrators of local public health agencies, our media, I'd been already working with media in the area for many years. So I had some good partnerships with the media already, people who trusted me to be truthful and accurate with the information I provided. And also just having a direct line, to our governor's office. We live in a Republican state, and just having that connection with their office, and knowing that we could have open, honest communication about what was happening throughout the pandemic, and they would listen and they would trust us and, you know, understand that we're not going to steer them in the wrong direction. And I think that that really helped kind of keep some of the politicization out of the messaging in those early days when we were fighting that issue.
Thank you. And Norm, you know, you mentioned that Virginia has quite a divide. What are some of the specific relationships that you think are really helpful in sort of bridging those divides?
If you look at a map of Virginia, there's really two states here. Cuts right through the middle. The northern half being very urban. The south side of Virginia, far southwest of Virginia, is very rural. Far southwest Virginia is essentially Appalachia and Appalachians. If you know the Appalachian community at all, it sort of crosses state lines, right? So you get southwest Virginia, eastern Tennessee, Kentucky, eastern Kentucky, and West Virginia. They're all there in the same area. And what we found was that we had to really target our information in such a way that when we reached out to Appalachia, the message that we had there, and for that matter, even in other areas of the state that were more Republican leaning, really focus on things like, you know, what can I try and think of a good example? People wanting to get back to things being normal, people wanting to really relate back to, they want to be back with their families and their loved ones and so on like that. So stressing that point and then explaining that the way to do so was, for example, getting vaccinated. That by getting vaccinated, you could hurry up and achieve that much desired value. In the African American and Latino communities, the thing that we found wasn't, for us, we didn't think it was so much a hesitancy of one, a lack of access, and two, not having the right messengers in those communities. Because of work that was done previously with the faith-based community in Virginia, we had the ability to really, we started what we call an ambassador program. Early in 2020, we had one meeting that was done by the Chief Diversity, Equity, and Inclusion Officer for the state. She got a meeting together of about 3,000 faith-based leaders from across the Commonwealth. In the Richmond area, the capital, we had weekly meetings of several hundred pastors and other faith-based leaders, and where we would talk about what we knew, what we didn't know, and all along the way try to keep them informed. And when we finally had a vaccine, they became ambassadors and explained the importance of getting vaccinated in their community. We went from having only a rate ratio of about 0.3 between the number of blacks being vaccinated, the percentage of blacks being vaccinated versus the percentage of whites, to reaching parity on that over several months, and more than parity with respect to the Latino community. And I think it was interventions like that that helped us to do that.
Time hearing, so it's I'm not sure if folks have if you stopped speaking yet, but I did have a question that I wanted for all of the panelists to respond to, and that is really looking forward. What would you like to do to prepare for the next public health emergency and managing the information environment, but you can't do for whatever reason? And Lisa, maybe you can help me out if my audio sounds terrible.
Yeah, sure. So I think probably, you know, as a communications lead, probably a lot of people in my same boat within their health agencies struggle with the fact that we're typically understaffed. Usually communications departments, we you know, keep adding on more and more and more, but don't always get additional staff. And that's certainly been a struggle for us. We have actually at the peak, we have had 4 people related to state public health communications in our state for, you know, 6.1 million residents. And so that's been a struggle. And like I mentioned, we have 115 local public health agencies to communicate with, and that trickles down into their communities. One of the things that we are really grateful for that will be happening in the future, and it's thanks to CDC grants, that we're going to be adding a contracted position as a liaison between our department and all the local public health agencies to really help facilitate all of that information that's coming from the state level to them, that's coming from CDC to us to them, just to make sure that there's more consistent, constant communication going on from the national to the state to the local level. Obviously, we did that to the best of our ability here in Missouri, but being having so few people to help with that, on top of the media relations demand and everything that comes along with it, building websites and responding to constituent inquiries and all of the different things that we had to do. Sometimes we didn't do the communication to the best of our ability. So we're really excited to bring on an individual that, once again, people already trust. Trust is huge. Well known in Missouri among local public health agencies. And I think she's going to be a really great way that we can kind of bridge any gaps that do still exist today. So I'm just a huge proponent of expanding communications teams as much as possible.
I couldn't agree more with that. Let's turn. Yes, go ahead.
Just to double tap on what Lisa just said, I'm a strong believer that we have to build up our communications staff, specifically around things like social media, and we had no one to work on that, and that's true. We need this staff not just for COVID-19, but for all the various disasters that we have to deal with. I mean, with COVID, obviously, we were in the lead in our incident response there, but in other things like the tornado that in Joplin, or hurricanes that we face every season here in Virginia, there's a huge communications need, and and when you talk about targeting different communities, I stressed the Black and Latino communities, but rural communities with something like tornadoes and hurricanes, they are really hard hit, and being able to deal with communicating with them, where you have all kinds of issues around lack of broadband access and other things, it presents other challenges. So you need the social media, you need people who really know how to access communication avenues in rural areas, and you need people who know how to alter that, not alter, but target that message for those different communities. So I'd say our preparation really includes a lot of development of our existing communications workforce and expansion of that workforce, adding numbers, building it up. And also, like I said before, building the partnerships, because even if we got a really great number of staff, there's still the need to do things like we were listening earlier to things regarding infodemic surveillance. Partnering with an academic institution or private industry would really aid us in the ability to do that. We don't necessarily have that kind of technology and expertise within our departments, and we need that, and we need it for the next disaster, whatever that disaster will be.
I think that's a perfect segue. That's where we come in, to be able to provide those kind of tools and resources. That's really the mission of the Anti-Infodemic Center. To answer your question, Hilary, what would you like to do? We want to turn our proof of concept into a production resource for public health organizations.
And say more about that. What would that look like? How could I, as a local public health practitioner, access that?
So there'll be two methods that we see. One is kind of the full service. You want to know what the threats are, where we've identified a threat, we have done the research and figured out what is the evidence behind it, and made a specific recommendation. The other is you have a threat, something that you've seen locally, and you want to know what is the evidence, what do I need to know about it, and that's where you can go straight to the search engine that we're building that will give you the top level information you need. Our goal is to then, based on our classifications, if we haven't seen that particular threat before, try to make some very general recommendations. Now, this is a conspiracy theory. This is a general way to respond to this kind of conspiracy theory. We know that the stories, the misinformation keeps changing. So we want to build the tools that will help identify how, in general, you are best able to respond.
Thank you. Lisa, what do you think of this kind of technique and tool? Would you be able to use it and put it to good use, do you think?
Absolutely. Absolutely, most definitely. I think that'd be extremely beneficial. Any additional resources to help teams, practitioners like me, be more efficient, add manpower in a sense, would be extremely helpful. And then something he just said, as the situation kept evolving, we could not predict what we would be responding to, similar to his Lucifer situation. That's not something we could have predicted in 2019, right? And we couldn't have predicted that, there were vaccines that caused issues among the Catholic Church. We have a lot of small rural communities that are mostly Catholic, so that hit us pretty hard. But once again, thankfully, we had a strong relationship with Catholic dioceses in our state, and those leaders, those bishops, were able to push out communication about the actual Catholic viewpoint on these vaccines and how it's all about the greater good. So just kind of going back to that again, you never know what you're going to run into and who the most appropriate messenger is going to be. So relationships of all kinds are truly, truly helpful.
For Ian, does your center look at misinformation only at a national level? Can the center localize, and how local can your analyses get?
That's a really good question, and we're not just looking at the national level. One of our big challenges is, because we are kind of the opposite direction, because we are an international center. One of our questions is what piece of misinformation that's circulating somewhere can have an effect locally. So we are looking at all the levels that we're able to look at. Certainly, we can go down to the state level. We can go down to individual city level. The more granular you get, the less information we have easy access to. But that's certainly something we want to do, and it's a question of resources and scale. The more fine-grained you want, the more resources it takes, because there's that many more locations that we need to follow. But certainly we've noticed that things that are true for a particular diaspora. We can see from a Mexican community, or from Mexico, we can see applied to a Mexican community within the US and things like that. So that's something we also are able to do.
Great. Well, thank you. I think we're almost out of time, but I just want to invite the panelists to just make a closing remark if you had anything else you wanted to add at this time. Norm, do you have something to round out your remarks with?
I would say that the most important thing that I would take away from what I've heard all this morning in terms of preparedness for infodemics in the future is building up our workforce that understands this science. And I'd want to underscore my suggestion that we as public health practitioners need to join with and partner with scientists in this field in academia and in private industry to really be well prepared for what's ahead of us.
Thank you. Yes. Lisa, any last comments from you?
Yeah, absolutely agree with Norm. I would also say that, obviously we got the public's attention through COVID-19. We were sort of, I think, in the background behind the curtains before that. But now that we have their attention, it's an incredible time to show the public what all we do, what all we offer, how we are working to change the health outcomes of the citizens of our state. And so we're really using that platform that's been built over the last few years, come for COVID, and we will show you everything else that we're here to improve for our state. So again, just a great time as we get closer to this next phase of endemicity, really, to work to gain that trust and show them that we're more than just a pandemic response organization. Thank you.
Thank you. And Ian, any last comments from you?
I think as we've been working through this, we've come to the realization that everybody knows that it takes a lot of varying disciplines, a lot of skills to be able to respond to an infodemic. Our customer base are people like yourself. They are the ministries of health, they're the state health departments, they're the health communication teams. But ultimately, we also know that to get the effect we want, it is those relationships that you build that help to get the story out. So there's only so much that we can do. The proof at the end is in those communications, and the communications on a local scale.
Well, thank you all so much. And thanks again to our panel for your remarks. And thanks to everyone for your patience with my technical difficulties. We're now going to take a 30-minute break, returning at 2 p.m. Eastern time. And when we return, we're going to be moving into conversations around infodemic response moderated by Allison Arwadi. So we look forward to seeing you again in 30 minutes. Thank you.